Are we good to go?
Yes, we are live now.
Good evening, everybody. It gives me a
Sanjay,
great...
I'll open and then I'll hand it over to you.
All right. Okay.
Good evening, everyone. Namaste and welcome to Diabetes Bytes by RSSDI. It is a social connect initiative aimed at increasing the outreach of RSSDI, in increasing the awareness of diabetes and activities of RSSDI itself. Today, it's all about diabetes and foot care. We want our people with diabetes to have happy feet and happy them. We have a fantastic panel lined up today for the discussion, and I request Dr. Sanjay Agrawal, our
I think
esteemed
Bansi is there. Why don't
expert
you...
himself, as the Secretariat of RSSDI, to introduce our panel and guests for today.
Thank you, Purvi. Thank you for the honor. And it's a pleasure and honor to be on this show and as well as introduce our eminent guest. We've got a wonderful panel who've got tremendous amount of experience in feet and diabetes, feet problems and diabetes. And I'm not going to waste too much of the time. So I'm going to just introduce you to our eminent panel. Our guest for today is a very senior diabetologist from the country, Dr. A.K. Das. Dr. Das is presently the Professor of Medicine and Professor and Head of Endocrinology at the Pondicherry Institute of Medical Sciences. He was former Senior Professor of Medicine and Endocrinology and Head of Endocrinology and Dean and Medical Superintendent of Jawaharlal Institute of Postgraduate Medical Education and Research at Pondicherry. He's taught the medical undergraduates and postgraduates in medicine and diabetology for more than 33 years. And he's a member of Physician Research Foundation of Association of Physicians of India. He's a patron of RSSDI. And the list goes on, but in interest of time, I'm going to stop here, but I'm sure all of us know Dr. A.K. Das well across the country.
Thank you.
Our next panelist that I'm going to introduce is Dr. Srinivas Murthy, and he's going to moderate today's discussion. Dr. Srinivas Murthy is a very senior consultant physician and diabetologist at the Life Care Hospital and Research Center in Bangalore, and he's a former consultant at Fortis Hospitals and Gleneagles Global and Apollo Hospitals. He's got a vast experience in both undergraduate and postgraduate teaching at the B.R. Ambedkar Medical College in Bangalore. He's faced successful US FDA audit in the field of research, and he's faced world's first ever Canadian audit outside Canada successfully. He's been a principal investigator for more than 65 clinical trials. So I'm sure he's got tremendous amount of background by which he's going to quiz our panelists, and I'm sure we're going to have a very interesting discussion forward. And our third panelist is Dr. Sanjay Reddy. He needs no introduction. I think everybody across the country knows Sanjay. A good friend, and I don't know how I should describe him. A good human being, an excellent academician, a wonderful speaker, and he's a consultant diabetologist at the Center for Diabetes and Endocrine Care at the Fortis Hospital, Bangalore. So over to you, Srinivas, to take the proceedings further, and I'm sure we're going to look forward to all interesting discussions.
Thank you, Dr. Agrawal, and welcome all of you. Dr. Srinivas Murthy, if I can just take a minute. Dr. Banchi Sabu, the president of RSSDI, is also here with us, and I'd invite him to just say something to our audience and kickstart the session today.
Thanks, Purvi. I'm sorry, actually, because of some connection error, I could not join early. I am trying since last 15 minutes. And today we have very eminent speaker, our patron, Dr. A.K. Das, past president of RSSDI. Along with them, we have two young and eminent diabetologist of Bangalore, Dr. Sanjay Reddy and Dr. Srinivas Murthy. This social media platform which we have started since last 6 weeks, me and Dr. Sanjay Agarwal, who is the primarily responsible for making this to happen, and then Dr. Purvi, Dr. Shalini, and Dr. Amit Gupta, who are executing this social media platform. Now, sir, just to inform you that now we have more than 10,000 followers from the community. The primary idea of this social media program is that RSSDI should be recognized more in the society. They should know more about the diabetes, and primarily we are doing this program to create more awareness for diabetes. And this is the only way by which we can prevent diabetes or diabetes related complication. Over to Dr. Purvi for further proceedings. Thank you once again. Thanks, Dr. Sanjay and Purvi.
Thank you so much, Dr. Agarwal, Dr. Sabu, and I hand over the session to Dr. Murthy.
Thank you, Dr. Purvi, and namaste to everyone. Hope everyone are keeping safe. And it's my privilege and honor. I sincerely thank Dr. Bansi, our president, and Dr. Sanjay Agarwal, our secretary, and Purvi and team for giving me this opportunity to quiz one of the teacher of teachers. Professor Das has been examiner to our senior batches, and we were scared about him when he was examiner for PG courses. And today I've got a privilege and honor to question and quiz Professor Das. And this is the greatest day in my life, I would say.
Very good.
Clinician. Because we know sir from many years, and he's been a greatest clinician. Everybody is a physician, academician, all that. But clinician is something where the Professor Das is apart. He stands away from the usual crowd. And that is what we have learned a lot of things from him, from what we call as a bedside clinics. So I'm sure all of you will have a lot of doubts about diabetes and foot care. And we have none other than Dr. Das and with my good friend Dr. Sanjay Reddy to answer your queries. Please send your questions as early as possible so that we can try to cater to all your doubts. And this is an innovative thing from our RSSDI team. We are doing weekly about each topic. And today the topic is foot care. And now why this topic is very, very important, because we know there are about 250 million diabetic patients in Southeast Asia, and out of which 60 to 70% of the diabetics eventually will suffer from this something called as a neuropathy. We are going to discuss what is neuropathy, what is the nerve involvement, what are the implications, and 60 to 70% of diabetics eventually will develop this peripheral neuropathy, what we call as a complication. And 9 out of 10 of these peripheral neuropathy patients complain of the severity of the pain, moderate to severe pain, and mostly these pains worsen in the nights. And once the night sleep is disturbed, it has got a vicious cycle involving the metabolic derangements, what we call the sugars, the lipids, everything gets changed, and the activities of daily life, like their exercise, their activities of daily life gets affected because of this pain. And that's the vicious cycle it sets in, and eventually with a lot of complications. Remember, every 18 minutes, there is an amputation done across the globe because of diabetes. Every 18 minutes, one person is losing part of their limb. And that is the severity, seriousness. So let me begin with asking Professor Das, sir, what do you think the clinical implications of diabetic foot problems and diabetes per se, sir?
My dear Dr. Srinivas Murthy and our president, our secretary, Purvi, and my dear colleague, Sanjay, I'll be very brief to mention that the clinical implication of diabetic foot is great. We have about 1 million diabetic foot amputated every year globally. And in our country, we have at least 100,000 diabetic foot amputated every year. Just see the number. And I would add to it that this diabetic foot, which are amputated in our country, are mostly neuropathic foot, which gets infected. In contradistinction to neuroischemic foot, where amputation is the order, where the blood supply comes down because of old age, smoking, atherosclerosis, fat being excess. That is a different issue. Many things can be done, but diabetic neuropathy is what our chairman just now described. It is just an insensitive foot, and by protection, we can prevent diabetic foot amputation. We call it eminently preventable. So the impact of this diabetic foot amputation in our country, which is about 70 to 80%, is great. I'll finish by saying two very simple examples for everybody in India to know. Number one, my dear friends, हम ये बोलते हैं कि there are two rules. Rule of 15, 15 का एक रूल है, 50 का एक रूल है. 15 का रूल ये बोलता है कि out of every diabetic, he has a lifetime risk. उसके लाइफ में हो सकता है वो 15% चांस है that he will develop a diabetic foot ulcer. Second 15 का ये है कि out of this 15% will develop bone infection, diabetic osteomyelitis, and totally 15% out of this will go for amputation. Coming to rule of 50, it is very scary in our country. 50% have major amputation. ये जो बोलते हैं कि below knee और above knee, ये knee के above में या knee के below में amputation करते हैं. Transfemoral or transtibial amputations is at least 50%. Number two, if you have one side amputation, the other side amputation is in 50% in 5 years. And last, 50% die in 5 years. Therefore, the implications of diabetic foot in a single sentence is huge and devastating.
Great, sir. Thank you very much for that insight. So remember, people, that 50 to 80% of the amputations can be prevented. That is what we should take the good points from what Professor Das just now said. And remember, more than half of all limb amputations are due to diabetes in our country, and risk is 40 times more for amputation in a diabetic. Dr. Sanjay, you want to pitch in and talk about the prevalence and incidence in our country?
Dr. Das, sir, it's an honor to be along with you, and Srinivas, my good friend, and Bansi and Sanjay and Purvi, thank you for putting me here. I would give my credit for my education on the diabetic foot to Dr. Das. He probably doesn't know, I'll tell you. My first time, he was one of the honor, I had the honor in 2003 to be part of the Diabetic Foot Society of India meeting, my young post-MD days. And what we realized, and I was responsible for starting these foot clinics, at least in Bangalore, some of them. Now, the most important thing, I have a small saying, Srinivas, you take care, for every of my patient, start examining the foot first. Please take care of your foot better than your face. Rule number one. Prevalence is like this. Every amputation, as you told me, 50% of amputations in the world today, from 50 it has gone to 70% is because of diabetic foot complications. So idea is start preserving the foot and give its care like your face. The amount of time you spend yourself to look at your face every day, please give double the amount of time to look at your feet if you're a diabetic. That is the only answer, and will also over a period of time tell you what are the simple things you need to take care of diabetic. Our country, socially, culturally, is very different in terms of wearing foot care. People will not tell you, leave your footwear. In the south of India, it's too much. And Dr. Das, Srinivas, and others, I don't know, across the world, when you enter a South Indian home, below the windows is that leave your footwear outside. Don't come inside with footwear. Most of our people don't wear. Most of our people don't wear footwear too. So rule number one, not my statement. This is the statement which I took from Dr. Das, and I borrowed you, sir. Every person.
We'll talk about, Sanjay, we'll talk about the preventive aspect at the end of our discussion.
The prevalence and incidence is very high. Most important is how do we prevent it? Go ahead.
Correct. So I think that's something. Of course, leaving footwear outside in this COVID era might be useful in that context as well. But for a diabetic, it is not a good sign at all. So now let us look at how do you identify this problem of nerve involvement in the feet. That means the symptoms and the signs. Signs are something which the doctors will pick up. Symptoms is something the patient is going to tell. So we need to categorize and identify what kind of nerve fibers. There is something called as nerve fibers, which are large, which are small. Of course, these are all too technical, but definitely we as a clinician will try to identify which fiber is more, and that will obviously lead us to what kind of investigation we should do and what kind of treatment we should do, plan for the patient. So, Professor Das, can you please enlighten us about the symptoms and the signs what clinicians will look for as a bedside, simple bedside when the patient comes for an OPD, outpatient?
I think it's a very, very relevant issue. To make a long story short, the diabetic nerve affection, as you rightly said, is primarily a sensory affection. It can also affect the motor. It can also affect a type of nerve which controls our autonomic nervous system. But in 90%, it is a sensory nerve affection. So the symptoms it produces are 4. Tingling, you feel झिमझिम होता है. Numbness, हमको मिलता है कि जैसे पैर नम हो गया, उसमें सेंसेशन नहीं है. Number 3, ये जैसा pins and needles, sensation of pins and needles, as if somebody is pricking with a pin or needle. आपका पैर में your feet is being pricked by pins and needles. And last one is feeling hot and cold, or totally loss of every sensation beyond numbness. We call it loss of, we'll come back to it, protective, but loss of sensation is one of the important. These are the symptoms. Therefore, we have, when that issue comes, I will highlight it. We have a 2-minute, and now we call it a 60-second foot examination. So these 4 questions important. Now, if you come to the signs of neuropathic foot in a diabetic, there are 2 important issues. Number 1, that you will find if you test with cotton wool or with a pin prick, you will find that there is at least a subjective, the patient feels that compared to the above the knee in the feet, the sensation is less, the pain sensation by pin prick and touch sensation by the cotton wool. And also he feels, and also when you elicit the एक jerk होता है, ankle jerk, हमें ankle में ऐसे एक stick में we just slowly hit and the ankle jerk gets absent. So there are many definitions, but all over the world today, हमने जो signs देखते हैं, what doctors want to elicit to diagnose neuropathy are 2: lack of sensation of pin prick and touch, and of course vibration. Will come to it a little later. And number 2 is the loss of ankle jerk. So that is what is called the diabetic neuropathy in the simplest term.
Thank you, sir. Sanjay, you want to add on some autonomic symptoms, what we call? So the autonomic nervous system basically means the nervous system which is not under your control. Like your heartbeat, it keeps on beating on its own. You don't control it. So that is called as an autonomic nervous system. And Dr. Sanjay is going to talk about some symptoms of autonomic nervous system which are typical of your nerve damage because of diabetes. And go to Sanjay.
Srinivas, autonomic nervous system is very difficult to elucidate or prove by a test. The best thing on autonomic nervous system on experience is trying to look at your sweating. Feet which sweat, never ulcerate. Rule number 1. Second thing which you see is something called postural hypertension and heart rate. No, for a physician who's treating on a day-to-day basis, trying to check postural hypertension in patients and looking at heart rate would be a big difficult issue. But for me, clinically, very simple. If somebody has dry skin, very dry skin, suddenly you find their feet are so dry, that's also a sign of autonomic dysfunction. Second, and these are simple things which you need to do bedside. You see somebody scratching. Dry skin means there is no sweating, meaning to say there's something which is wrong with autonomic system. Third is trying to look at the heart rate, the fall in blood pressure for somebody who's lying and getting up. So these are simple things. And another thing which comes on with all this vascular issue is also something which is not at the purview of this, is the erectile dysfunction in men. And these all things are related to autonomic dysfunction.
Exactly,
So,
Sanjay. I think you got
okay.
the right point. The
Yeah,
loss of libido.
I think, Srinivas,
Sir,
one important issue, as Sanjay pointed out, 5 signs that if we can easily find out, or everyone with diabetic or the family members can find out. Number one, as Sanjay pointed out, is a dry skin which is fissured or cracked. There's cracks
Exactly.
and the fissures. Number two,
Right, sir.
because of the cracks and fissures and lack of sweating, the hair disappears. May disappear or maybe become sparse. And third important issue, that because the arteries open up, what we call the artery and vein become combined, AV shunting, artery vein combining, this foot may feel little warm because it's a highly vascular foot. And final thing that I would like to point out, that today this autonomic affected diabetic foot is very important to diagnose, because that also gives you the indication that it is a cardiac risk marker. So if the person has got autonomic neuropathy or has got diminished blood supply, which will come in a minute, that also becomes a marker for the heart disease. We call it male health initiative, to find out the blood flow in the feet and also the autonomic nerve involvement.
Great, sir. And just to add on, sir, the symptoms
Yeah.
for autonomic nervous
Yeah.
system. Now, I think
Yeah.
Sanjay and you rightly pointed out
Yeah.
the signs,
Yeah.
what a doctor would elicit. But the patient's common, one of the things is nocturnal diarrhea, alternating diarrhea and constipation, and something
Absolutely.
called as diabetic gastroparesis,
Absolutely.
where they have fullness,
Yeah.
slowness, difficulty in digesting things. That is the commonest thing they come out. No, it doesn't digest, and I always full. I eat very little, but it is a full sensation, and that is something which is commonly told by patients, and we need to pick it up. And then what people just now said, that rightly, the signs, the dry skin is one of the common, especially the feet, the fissures, as you rightly said, sir. One of the commonest things which people tend to neglect, and they try to keep it in a warm water and cold water, the feet, and that's one of the things. And remember, these symptoms, what Professor Das was talking about, the pins and pricks, the jum sensations, mostly they worsen in the nights. And that's the time you should come out and please tell your doctor that these symptoms you're experiencing. Because one of the studies have shown 50 to 70% of the patients have difficulty in expressing the symptom itself. Because in South India, we call something like a shock-like sensation, we call in the local language, there is a slang which say there is a shock-like sensation happens in the nights. And that's all, otherwise I am fine. And many patients do not reveal it to their physician, because while in the busy OPD, we may not do tests for every feet. Of course, we are supposed to do, but in a busy OPD, we may miss. But once you give us a symptom, a clue, we will definitely go ahead and examine and treat rightly. So going forward, sir, what are the tests? They're expensive tests, or we can easily test this nerve damage or neuropathy in a diabetic feet. So what are the tests we can do in 2 minutes, 60 seconds? Can you please guide us on this?
I think I have told you the what symptom to elicit. Do you ever feel numb? Do you ever feel that there's an abnormal sensation in your feet, mostly in the night? Number 3, that do you have any other symptom related to your sexual dysfunction or urination, sometime bladder becoming full, etc., etc. And the signs that we elicit, number 1, as I told you, I will not repeat it again, but we also try to examine the vibration sensation by the 128 tuning fork. So that is 3 things: pinprick, cotton wool, and the vibration sensation by 128 tuning fork. And if you come to the test that we must do, they're very simple, Srinivas, and very inexpensive. I will advocate only 3 tests. Number 1, a test of a pinprick. Number 2, a test of pressure by a Semston-Winston monofilament. That's a 10-gram monofilament. And we always say that if somebody is not able to feel the sensation of the monofilament while it is buckled, this is a diabetic foot at risk. And if one can afford, one can go in for a sensation, what we call vibration perception threshold, that costs about 30,000. There is no recurring cost, one time it. And we look for the vibration perception threshold. If it is more than 25, highest is 50. It's a diabetic foot at risk. Between the 15 is already diabetic neuropathy. 15 to 25 is at risk for neuropathy. So these are the basic minimum. But there are many other tests that are available today, like doing the diabetic foot pressure, doing the heat and cold sensation. There is also a test sensation called the heat and cold pain sensation, the differentiation. And in addition to this sensory test, there is another test which can identify neuropathy, is the handheld Doppler. It costs between 8,000 to 14,000, no recurring expense, and this gives us the ratio between the blood pressure in the arm and blood pressure in the leg. And this is important for the neuropathy because the ankle brachial ratio in neuropathy is usually more than 1. And we'll come back to ischemia later. So these are the basic tests. I'll repeat again. Pinprick, same symptom monofilament is a must, and that's a must. That is a must in every clinic. And of course, a tuning fork or biostationometry, and a handheld Doppler to identify the neuropathy and distinguish it from the vasculopathy.
Thank you, sir. Thank you. And the cost, what Professor Das was alluding, was one-time investment for the doctors. It's not for the patients. Patient need not invest 30,000 to buy the Bytes. They charged about 100 rupees for the examination. And the monofilament sir was talking about, and the vibration, it doesn't, no doctor charges you for that. It is for the doctor to perform it for within 30 seconds and do it and elicit that. So it is for the physicians who are listening to that. The cost is one time. The handheld doctor is about 8,000 and 35,000 for the Bytes. Sanjay, what is the frequency a doctor should plan or a patient should plan for these tests? Should they do it every month, every year, every 6 months?
Srinivas, there are two types of things. One, every time the patient walks into your clinic, start with examining the feet first, not the face. Rule number one. Any diabetic patient walking into our clinic, whenever he comes in, just feel for the pulses. As Dr. Das was telling, look at his skin, look in between the toes, look behind to see if there's an ulcer, something or else. Every year, to do a biostationometer assessment, or monofilament you can do any time in the clinic. Biostationometer gives a quantitative estimation of neuropathy, and doing a ABI every year helps to assess the vascular, meaning to say the blood flow. अभी समझो आप ये कर रहे हैं, आप किसी को देख रहे हैं, उसका हालत क्या देख रहे हैं? दो थे, आपका पैर ठीक है या उसमें दो तरफ की प्रॉब्लम हो सकते हैं, एक नस का, दूसरा पाइपों का तो ब्लड फ्लो. So these two, every year, every time a patient walks in, जब भी पेशेंट आता है उसका पैर पहले छुओ, उसके बाद उसका चेहरा छुओ. पैर को देखो, सिंपल हाथ लगाओ, सब पता चल जाएगा. उसका नस का बारे में पता चल जाएगा और उसका वैस्कुलर प्रॉब्लम के बारे में पता चल जाएगा, एंड ऑल्सो द प्रॉब्लम विद हिज फीट. Every year, quantitative estimation in a diabetic clinic once a year. Otherwise, if it's a high risk foot, every 3 months or 6 months you need to look at it. High risk foot, so if you have already 1 feet already into diabetic foot problem, you do it more frequently.
So one take-home message in this.
Beautiful. Sanjay, 1 minute. That we have, as rightly pointed out by Sanjay, we have given a guideline, exactly what Sanjay said. If somebody has, as he rightly said, a foot ulcer already, Srinivas, or already has a amputation, the diabetic foot has to be examined every 1 to 3 months. I think Sanjay is prophetically correct. If the person has got loss of protective sensation or has got a peripheral arterial disease by ankle brachial ratio, we say it has to be examined every 3 months. If the person has loss of protective sensation, that's what Dr. Sanjay said, that the patient has got a protective sensation loss, then we have to examine it every 6 months. That is, he called diabetic foot at risk. If the patient has no neuropathy, still once in a year, one has to examine the foot. So 1 year, 6 months, 3 months, 1 month. That is the thing we have put it in our guideline for the diabetic foot.
Great, sir. Thank you. And the take-home message for audience is that once a year you need to get examined your feet. So your doctor might forget. So please remember that you need to get examined your foot. And if there is an ulcer, which is going to be a very serious issue, that's what people should remember, because more than half of the foot ulcers will become infected. And once infected, 1 in 5 require amputation. 1 in 5 out of 5 patients, if their feet is infected because of an ulcer, they will require amputation. That you people should remember. So it's your responsibility equally that you should ask for the examination once a year to your doctor casually. I mean, that is your responsibility equally, though the doctor might advise and he may forget, but it's your duty. So take-home message is very clear. Now, coming to what are the other conditions? Sir.
Sanivas, 1 minute. The Paul Brand, who is the father of diabetic foot, Sanjay, you know Paul Brand of the Karigiri fame.
Yeah. We both of us met him. Bratislava.
In his last address, about 4 years back, he was asked to give an oration, and he was asked at the end of the oration, what is your message regarding diabetic foot to the people who are with diabetes? He said only one thing: if the doctor is not doing it, please request your doctor to take out the shoes and the socks of your feet and to have a look at your feet. Just see the intensity of what you said, that if the doctor is forgetting because of it is the duty of the person with diabetes to remind the doctor, and it is not offensive. It is absolutely in fitness of things. Absolutely. Yes. I think you have taken the most important thing. Paul Brand said, the latest advance is to take out the foot, take out the shoes, take out the socks, have a look at the feet and the shoes and the socks.
We were both, me and Dr. Das, at the same meeting at the time.
Sanjay, now what are the other conditions, medical conditions, which can worsen your diabetic feet or neuropathy, what we call
very good.
The other conditions?
Very good.
Which we should ideally identify and treat parallelly.
That's a very valuable question. Every patient who's a diabetic doesn't have diabetic foot. That's a lovely question as a physician to ask me, and I'm speaking to one of my teachers and trying to understand everything, because neuropathy is something all of us know. बहुत सारा कारण हो सकता है. I was asked to speak at least कारण हो सकता है. Majority of our patients, when I see elderly patient, 20-year diabetic, never complained of diabetic foot, comes to us, vegetarian, telling us he has some problem with the feet. No problem with the feet. You do an assessment, everything is normal, but still has positive symptom. One of the most common things in the world is looking at B12 deficiency.
Vitamin B12 deficiency.
B12 deficiency is
vitamin
one.
B12.
B12 deficiency is one of the commonest causes which you have to rule out. Other things which are associated with neuropathy are innumerous. Trying to ask the profession of the patient. Now, if you go to the village, I practice in a village. You ask him sensation in the feet, he will not tell you, because there's no sensation in the feet. I go to the village, every fellow is walking barefooted on the village, no sensation in the feet. You need to individualize this. This is very important, trying to know their profession. The reason is, because of their profession, they lose certain sensations. Somebody, I know Dr. Das will understand me, working in the jaggery factory, doing jaggery or doing cane sugar. His feet is always exposed to a hot temperature. He doesn't know difference between hot and cold. Idea is there are many associated conditions with diabetes. Important. If the blood sugars are not very controlled, they have the most important thing. At diagnosis, 14% of people, it's called the Cindy study, which we are part of, says 14% of the patients who are diagnosed new come back to you with a symptom of neuropathy. Some jum ho raha hai sir, isliye aa gaya. Sugar check kiya. Most important thing, get the glucose under control. Third thing, there are various metabolic disorders which are associated with neuropathy. Every neuropathy in a diabetes is not diabetic neuropathy.
Sir, you want to add on, sir?
Dr. Das has told.
Yeah, I think.
You can add on. Sorry, on the clinical aspect. Please go ahead.
Other comorbid conditions which we should differentiate and take care equally.
Absolutely. It's very, very important. The usual comorbid condition that is of late becoming important, Sanjay and Srinivas, is diabetic kidney disease. We have termed a term. You remember, Sanjay, you were there when Andrew Bolton gave the
Yeah.
talk. We have called it diabetic renal foot. But for the people with diabetes, I would say, if somebody has got kidney problem, if somebody has kidney failure, has got being on dialysis or being a renal transplant patient or severely albumin salt going in the urine, patient has a more chance of developing neuropathy. This is an important comorbid condition, and the patient lying down for dialysis for 4 hours, and if it is a flash dialysis, at least for 3 hours, in the heels they develop ulcer. So that is kidney disease. The second comorbidity, which is well defined today, are two. Number one is obesity, and number two is limited joint movement. Now, limited joint movement is like this. आपको मैं दिखाऊंगा कि you do it, you namaskar, you are doing like this. If you have a neuropathy, your joints will be like this in the hand also. So if while doing a pranam, namaskar, you will have the joint will not move well. And that has been recognized today as a very important comorbidity of diabetic neuropathy. So I'll say limited joint movement, not able to move the joint completely in the leg. And number two, having a kidney failure. And number three, obesity. And number four, if somebody has high fat in the body, we call it dyslipidemia. That means, as Sanjay said that beautifully, other metabolic factors, most important of them is diabetic, lipids, fat being high. And finally, a person who has alcoholic, because alcohol affects the nerve. Diabetes affects the nerve. It is 1 plus 1 is not 2. It's 1 plus 1, which is 11. I'm just telling to impress on the point, a diabetic must refrain or at least limit alcohol. Sanjay, am I correct? Because alcohol
No,
will
sir,
produce
I don't agree.
diabetes.
Sir, I don't agree. No limit. Because when you start
No
alcohol, there will not be limit. So we say stop it completely.
You must stop it.
You don't give a choice there
absolutely.
of the quantity. Sir.
Srinivas, I am a teetotaler.
Me too, sir. Me too, but I always want my patients also to be like that, a teetotaler, and especially with a diabetes background.
Yeah.
I completely
Yeah,
disagree.
Sir, I have done 30 years research on alcohol, sir. Let me tell you.
Yeah.
I know every alcohol.
On subjects or yourself, Sanjay?
No, on alcohol, not subjects. I'm talking alcohol only, and this has no benefit. It has
Great. So we will move on to the next question.
No clinical benefit at all. Done. And
that's a loud and clear message.
If anybody who's a diabetic, non-diabetic, wants to think about alcohol as a benefit, all this is nonsense. Please watch the initiative by BBC on Netflix, 1 hour alcohol. No benefit at all.
So, right. That's a loud and clear. It's been proven from ages, but still people indulge in that,
absolutely.
and nobody knows the reason.
And
people sit across a table and evaluate the reason why they are drinking most of the times, and that's what I feel as a teetotaler.
Exactly.
So let us move on, sir. Now, yes, sir. Now, the nail care or the foot care, as we are talking about, we need to take care of our feet more than like a face. So what is the advice when they cut nails, especially in the feet, to the diabetics? Sir, your words on that.
I think nail care is of paramount importance. I was trained in the British Diabetic Foot Lab for 2 years with Mike Edmund and Peter Watkins and Ali Foster.
Great.
And nail care was one of my projects, 3 projects we have to do. I'm very passionate about it. Number one, the dystrophic. आपने देखता होगा कि कभी-कभी आपका फीट में जो आपका जो nail है in the feet that become thick, वो ब्रेक हो जाता है या इसमें उगर में ऐसे पॉइंट आ जाता है, कॉल्ड डिस्ट्रोफिक नेल, एंड उसमें फंगल इन्फेक्शन होता है. सो डिस्ट्रोफिक फंगल नेल इज ए हार्बिंगर of a bad toenail leading to ulceration. What it produces ulceration, septicemia, and ultimately amputation. Number 2, how do you take care of your nail? 3 principles. Number 1, you must take nail care, as Sanjay said, as you take your face care. in the sense that you have a system of cutting the nail. Do it after taking bath when the nails are soft. Number two, you cut it straight. You cut it straight and never cut the sides, but it might injure the side skin and can initiate an ulcer. Third thing, there's a condition जब nerve उस तरफ जाता है, आगे तो आता है but it's also अंदर में जाता है, उनको हम बोलते हैं ingrowing, अंदर जाने वाला nail, ingrowing toenail. That has to be done by a trained person. You have to go to, we do not have a podiatric status. I think Dr. Srinivas will come to it in later. He's asked, but we at least go to a good sister, good nurse, good doctor who can take care of this ingrowing toenail. And finally, 5 infections: onycholysis, paronychia. Third, toenail having infection below the nail, which needs debridement. And most important is in between the nail, they can friction and develop kissing ulcer because of the lack of attention to the interdigital space, lack of attention to the growing of the toenails. आपकी ये हो सकता है कि 2 nails के अंदर में kissing ulcer हो सकता है. So I'll make again a last word summary that nail cutting is an art, and in diabetic, this art has to be acquired by the family members or the patient themselves or by the sisters. Nail is very, very important because of the dystrophy, because of the infection, because of the ingrowing, because of the kissing ulcer, and because of the initiator of diabetic foot ulcer.
Thank you, sir. Now we'll take up one audience question, sir. One of the eminent surgeons from Karnataka, Dr. Sunil Curry, who does a lot of work on the foot, diabetic foot.
Sunil Curry himself is very expert. So let us
Sunil,
what he's asking. Sunil?
So he's asking how to plan for the screening of this diabetic foot screening in the background of COVID-19 now.
Yeah, I think it's a very thought-provoking question. I think in the COVID-19 situation, we have brought out a guideline, RSSDI. IDF also has a guideline where we have said that except 2 situations, GDM, where 2 lives are involved, and the second is the diabetic foot ulcer, where you may need face-to-face audience, or you do what we call new language, virtual face-to-face. Chairman sir, I will tell you it is very important that 2 situations where you cannot do teleconsultation. One is diabetic foot, other is the GDM. I think Sunil Curry has hit the ball. The issue is diabetic foot, if you do not look at the ulcer, either face-to-face, or we have a new term, virtual face-to-face. What is virtual face-to-face? You just put the diabetic foot in front of the camera and let the doctor see it on all the aspects. That's called virtual face-to-face. The new term that we have coined, that it is not face-to-face because you may not be able to access the patient, but he can show you the face by the video camera, and you can see whether the ulcer is big, whether the ulcer has become necrotic. There are signs of ulcer becoming or advancing, whether it is osteomyelitis, whether the patient has a necrotic foot, he has a necrotizing fasciitis. Srinivas, you're understanding. Sunil Curry understand this. Therefore, in COVID-19, Sunil, I would say what we wrote in our guideline, we stand by it, that diabetic foot needs at least virtual face-to-face consultation, because we cannot do it only by a teleconsultation. So virtual face-to-face is important, and if necessary, because otherwise one will land up in amputation.
Yeah, you're right, sir.
Great, sir. So this chronic neuropathy, sir, we were talking about the nerve damage would result even in a bone involvement. It can go up to the bone. So something called as a joint deformities, all that. Can you please enlighten on that?
I think it is very important. It is called Charcot neuropathy. If we pronounce, I am in Pondicherry, French territory. Charcot.
Charcot is very, very.
We call it as Charcot.
No, it's not Charcot. It's Charcot. He and Dr. Das have debated long.
That is, yes, sir.
So it is actually.
Just to tell the common.
I'll tell you the common thing about it.
Yes.
My dear friends who have diabetic, who have don't call diabetic. My friends with diabetes or family members having diabetes, please remember that The cardiac complication is about 25%. Kidney complication today is about 30%. But neuropathy is almost 100%, because Allenberg said that anybody who has got tingling numbness has got neuropathy, and every diabetic gets tingling numbness. But what is important, when this neuropathy progresses, the protective sensation, the pain sensation is lost. Therefore, this foot which has got advanced neuropathy is subjected to repetitive injury, or we call it repetitive trauma. So, my dear friends, when your leg does not have this pain sensation, you must take extra care. What extra care? You need more protective shoes. We'll come in a minute. But this repetitive trauma makes the bones break inside the joint, and you will not know about it. So it is a bag of bones. Your leg gets swollen. It becomes a bag of bones, yourself not knowing it. So there are three things that happen. In the acute phase, there'll be a picture like cellulitis. You will find the leg is swollen, leg is little bit painful, a little bit red because of cellulitis. In the second phase, you will find that there's a lot of bone resorption. Bone is taken away. At this stage today, we have medicines which we give for the bone redeposition. We'll come to in a minute if time permitting. And the third stage, there's a reconstruction. Over this, the bone becomes deformed. The feet is not straight. The feet becomes very swollen. Bag of bones. There is all the bones are broken. There is no pain. See, the gift to mankind of the God is the PAIN. Because of pain, we survive. Because of pain, we exist. If there is no pain in the feet, it gets into repetitive trauma, fracture, bone resorption, reconstruction. 3 pages: cellulitis, absorption, and reconstruction, which features in this Charcot joint, which is advanced neuropathic joint. It can occur in other conditions. It can occur in syphilis. It can occur in da. We'll not discuss that. But in diabetes today, it is becoming more in India. You know why? Because of doctors like Srinivas ji and Sanjay, my friend Sanjay, the diabetics are living longer. God's grace above all, but the doctors also contribute quite a bit. If you live longer, the neuropathy is longer. And if neuropathy is longer, trauma is longer, and sarcopenia is longer. And that is preventable, that is treatable, there are surgery available, and if you do not take care, ulcer develops on this neuropathic joint, and that is devastating.
Thank you, sir. I think the message is very clear. You should not land up in that joint deformity, for which you require a regular control of your sugars, regular checkups by your doctor, and that is what you should follow. Sanjay, we have got another question from the audience. Dr. Vemula Vishwanathan is asking, can we give SGLT2 inhibitors, that is one class of drugs for diabetes, anti-diabetic drug, in foot infections? Can we give?
I think Sanjay would like to answer.
No. There's a lot of things which is gone with foot infection and SGLT2 inhibitors. One of the studies which showed was there was more amputation when you use SGLT2 inhibitors. That was with canagliflozin. Personal experience apart and research apart. When there is indication, one thing I feel in personal practice, somebody has a fungal infection, don't wait. Otherwise, if the EGFR is good and you wanted to give it for glycemic reasons, every patient who has a cardiovascular today asked me, if I don't prescribe the drug, my cardiologist call me. If they don't have heart failure, my cardiologist call me every day and say, why did you do that? So idea is 2. If you have a fungal infection, wait till the fungal infection is specified. And I don't see any risk to give SGLT2 inhibitors to my patient without a fungal infection.
No, it is not fungal infection. The question is very specific by Dr. Vemula Vishwanathan. It is foot infection. Can we continue or initiate?
Yeah, you can.
Exactly. That's the message. Very clear. So there is no contraindication except if somebody has got established peripheral vascular disease, chronic smoker, we don't give. Otherwise, we can definitely give SGLT2.
Srinivas, I would also differ, and I would ask my teacher.
Yeah, Dr. Das can
Or,
comment, sir. Sir, your comment.
Comment.
Somebody is
Yeah,
No.
chronic smoker, established
Yeah.
peripheral vascular disease.
He's an ideal candidate.
Yeah, I'll just come back.
Even if peripheral vascular disease is not contraindication apart from my
Yeah.
my
Yeah,
view. I
I'll
would
just-
like one.
Yeah, Dr. Das, sir.
I'll just tell you the things like this. Now, if the infection, Dr. Bimla Srinivasan, if the infection, there are 3 stages of infection. If it is mild or moderate, one can use the oral antidiabetics and SGLT2 can be used. But the advanced infection, be it fungus, be it bacterial, one has to give insulin. Second point, the smokers and the person who has got peripheral vascular disease, we avoid SGLT2 for 2 reasons, Sanjay. One is that now it produces dehydration, so there's a chance of ischemia increasing. But dear friends, I would like to say something which is very important, which we only drafted yesterday. For a diabetics who have dehydration, even in the COVID world, we give metformin, we give DP4 inhibitor, we used to give also SGLT2. Now, if the patient has dehydration, we do not give it because dehydration can produce also altered prognosis in a case of COVID. So, from that point of view, if somebody has a peripheral vessel disease, it may be that it can aggravate it, and that is about SGLT2.
Thank you, sir. So now let us finally talk about the treatment, which involves prevention, management, both. So how do you preventive steps for offloading? What is the footwear part? Lot of patients buy in a medical store footwear. They call it as a diabetic footwear. Now, should we go and buy blindly, or should we get examined by a specialist called podiatry? That is a division which examines and deals with the foot. So should we go ahead and buy a footwear of my size of shoe, or should I get examined and then buy a footwear?
Yeah, I think there are 3 principles. Yes, Sanjay.
Sir, this is my favorite question.
Yeah, please answer. Please take it.
I want to
quickly, Sanjay. We have got less time, so be quick.
Sanjay, your mic is muted.
Your mic is, internet
muted.
issue, I think. Sir, you can go ahead and answer, sir. Meanwhile, I think Sanjay is stuck.
We say, Sanjay, when you come back, you tell me. Yeah, he has come back.
No, I'm done. Yeah, okay. So the question is buying footwear. When do you buy footwear? Everybody should go in the evening to buy footwear.
Correct.
Because your feet, this is somebody who taught me, 70-year-old lady taught me how to buy footwear. First, draw a circle of your feet on the, and whichever footwear you buy, if you are a diabetic, slip that, put your feet on the ground, draw a circle of your feet, and put that same slip into the footwear. Anywhere, if it folds, that means it's not the right footwear. Okay, I love nice footwear, but remember, you need to buy good breathable footwear. Rule number 1. Second, buy it in the evening. Third, women buy all fancy footwear. We like these women and the footwear. And if it's a diabetic, how lovely they are.
Sanjay, I
think your internet connection is a problem. You're breaking in between. Your video is
I'm sorry.
Sanjay, there are 3 things. As you
can go ahead, sir. Professor Das can go ahead.
As you rightly pointed out 3 things, Sanjay. We say it must be FPA. F is it must be fit. Number 2, it must be protective. It must be accommodative. So I think what you said, it must be accommodative. It must be a little bigger than the usual size because the evening leg will swell up even beyond to give accommodative. Number 2, it must be protective. So if you have a very narrow shoe, as you said, your young girlfriends, madam is not there, I suppose, then then what happens? This can look nice. It does not protect. It rather compresses the feet. Third thing, it must fit well. But Srinivas sir, Chairman ji asked a very important question. I would like to tell to my audience very, very clearly, out of 100 people with diabetes, 93 to 96% do not need a customized
Special
footwear. I'll repeat again, the ordinary shoe,
I agree with you.
fit, protecting, accommodative, but in the evening, as Sanjay pointed out, is the one which is to be worn. Number two is that only 3 to 6% who have a deformed foot, like hammer toe, like a bunions, like a deformed, like a tarsal
Really?
bar which has come down,
Flat foot.
or a foot ulcer where you have to offload. I think you will come to in a minute. Then only we say that the patient has got a very special diabetic foot, customized footwear. Otherwise, we do not need customized footwear. And the final thing I must tell you, that when the doctor starts about the treatment, there's something called therapeutic footwear assay. We have to see the footwear. If in one portion is gone, people wear chappals where it's totally worn out. You can find out by looking at these shoes, where is the pressure point, which are the likely place for ulceration, where is the callus, we should take out the callus. I think Purvi has come, it means time is going out. Now, the other thing I must tell you, the treatment of the neuropathic ulcer, which is our main problem, is rest, offloading, and antibiotic. How do you go offloading? If the patient can take rest, you admit them, and is a severe ulcer, just give a total contact casting. Or today, many commercial, we are all using the commercial offloading. All that it means, that the foot does not come in contact with the ground, and the ulcer is not under pressure. It heals by itself. And you need antibiotic. We have got 3 stages of antibiotic. We have given the guideline, starting with oral antibiotic, going into the injectable, higher injectable antibiotics. For the ischemic ulcer, the treatment is different. How to differentiate ischemic ulcer from neuropathic ulcer? If the neuropathic ulcer is painful, ischemic ulcer is painful, neuropathic ulcer is painless. Ischemic ulcer, the feet is cold, neuropathic ulcer, the feet is warm. And third, neuropathic ulcer occurs at the pressure points, the pressure points of the feet. The ischemic ulcers at the sides. For a ischemic ulcer, the only oral drug is available, I'll go by the trade name, called silostazole. It may, many times it does not help fully, but it's a drug which can increase the blood supply a little bit. But the treatment here today is revolutionized. We have wonderful surgeons, interventional cardiologists in our country who do stenting, like the stenting in the heart, and the diabetic foot arterial block is taken away and they heal. And finally, what is most important for the diabetic foot is that once this therapeutic option is done, if the person has got severe infection like osteomyelitis, appropriate surgery. A person has got necrotizing fasciitis, appropriate surgical intervention. So surgery plays a role. And before I close, I must tell you that the prevention is the one which is very appropriate for the diabetic foot. As Sanjay said in the beginning, in Indian tradition, we always regard foot as very important. Just examine. The Bharat took the footwear of Rama. I'm not talking religion. And with the footwear, he reigned the Ajodhya for a number of years. Similarly, when Sudama came to Krishna, the Krishna washed his feet. I'm just giving 2 examples to say that foot in our religion, Sanjay hinted at it, is very important. We must take care of the foot and prevent. And every ulcer begins as a trivial breach of skin. And if you stitch in time, we save 9. So every ulcer begins as a trivial skin breach, and we can control it.
Great, sir. Thank you. And we did not talk about the medicines for the neuropathic pain, sir. The jum sensation के लिए क्या दवाई ले सकते हैं? Just 30 seconds if you can brief, sir.
Yes, sir. I think we have got 3 types of drugs. We give the drugs which are given for the epilepsy, and which are given for the tingling nerve sensation. The number 1 drug that is used today world across is pregabalin, because that is the drug which has stood the test of time. People use pregabalin 75 milligram bedtime, but when the pain neuropathy is severe, people also use gabapentin. I prefer pregabalin. The second drug that is used is alpha lipoic acid. That also has shown some benefit in the diabetic neuropathy. And third drug, which can be of some benefit in a diabetic neuropathy, is the drug which are anti-arrhythmic that we use in the heart, like mexiletine. But now it is given up. It does not give that
Yes.
much of relief. So we combine with the pregabalin, we combine with the gabapentin, we give little bit of drugs which can use if there's a sense, if there's a neurovitamin deficiency, we can sometimes give that. Alpha lipoic acid has stood the test of time, showing some benefit. But one
Great.
important issue I would like to say here,
Sir.
what Andrew Bolton told me again and again, we must tell the patient is a nuisance, having a pain in the feet nuisance, but it never compromises your life expectancy. Your life expectancy is 104, it will be 104. It's a nuisance to have this tingling numbness. Your life expectancy is full. Therefore, the person gets the confidence. It's only a nuisance. He's not going to tell upon my life.
Yeah, but as you always tell, sir, treat the root cause first. That is,
Yeah,
bring down
exactly.
your sugars, control your sugars,
100
then everything reverses.
Yeah, yeah,
Because
I
this is a
think-
chain
I think-
reaction which
yeah,
started because of your poor control of diabetes.
Yeah,
So
yeah.
all these complications happen. So
Yeah, I
thank you
think-
very
I
much,
think-
sir. We learned a lot of
I'll
things
just
from you
take
as
1
usual.
minute. Yeah.
Yes, sir.
I'll tell you
Please,
the
sir.
last that, controlling blood glucose is number 1, number 2, number 3. Because is hyperglycemic neuritic pain is most important. I had forgotten about it. You spoke beautifully.
Yes, sir.
Hyperglycemic neuropathic pain is number 1. That has to be eliminated by controlling blood glucose.
Thank you very much, sir. And
I
always
think
grateful to
Srinivas-
you.
Srinivas,
Thanks, Sanjay.
before-
And over to
Srinivas-
Purvi.
Srinivas,
Sir,
before
sir.
you close, just
Yes, sir.
Purvi, give me half a second.
Yes,
Today,
sir.
for the diabetics, we have decided what they should do the COVID time. Now, just understand the concept that we are in time zero when there is no infection, and the infection start at 0 point. Now the numbers are increasing by 100,000 every second day. Today we are 1900,000. We have said that beyond the 0 point, before 0 point, -1, -2, -3, -7 days, every diabetic, as Srinivas, our chairperson, said, bring the blood glucose under strict control by hook or by crook or by hook and crook. You give oral, give SGLT2, give insulin, give whatever you want to do. Blood glucose must be controlled, because we know if the blood glucose is controlled, the diabetics are not more susceptible, but diabetics have worst outcome. Number 2, even if a diabetic gets COVID on the day 0, please diagnose it on the 3rd, 4th, or 5th day, because they call rule of 3, 4, and 5. And if you diagnose and give the proper treatment, what proper treatment? You give steroids as a anti-inflammatory drug. You give the drugs like which takes care, like toxazolomab. If you believe in hydroxychloroquine, if you believe in the other drugs, you can give remdesivir, whatever you want to give. But the care, oximetry and oxygen, that is most important. Then the prognosis is better than a non-diabetic.
Sure, sir. Thank you very much. And we'll have one more program, maybe COVID and diabetes, sir. We'll definitely love to have you.
Yes,
Over to
definitely.
Purvi.
The pace of this session has kept all of us on our toes today. Very, very informative and extremely helpful. So big thank you to each one of you from the RSSDI social media team, including Dr. Shalini Jaggi and Dr. Amit Gupta. And I request Dr. Sanjay Agrawal to hand over the vote of thanks.
Yeah, but before that, on behalf of Sanjay and Srinivas,
Other
and on
Sanjay.
one behalf, we three musketeers enjoyed much more than
Then
anything
all
else.
of you. Okay.
And we
Let me.
wait, yes, chairperson.
Sir,
Sir.
Thank
I
you
want
very
to make
much.
a statement,
Thank
sir.
you. Just stop.
Before Sanjay, you make a statement, I want to tell 2 things. One, thanks Purvi and Sanjay, Amit and Shalini for doing a social initiative. I love this.
Great.
This, sir, I don't know. I really love it. I want to do it every day now.
Correct.
I'll tell you what, thanks Purvi. I love it every day. This is without any interference of no pharma. Sir, every day we do all this now for ourselves. But listen to me. The first time I love this, Sanjay and Bansi, big, and Purvi and Amit and Shalini, a big thank you. This is one of the
Thank you.
best you have done.
Deep gratitude, and we owe it to Dr. Banshi and Dr. Sanjay.
Yeah. Big clap.
Thank you all of you.
Hey, this is one of the best you have done.
Thank you so much. But I'll also take this opportunity to introduce our new committee members in the social media team. So we have expanded
I'm not social.
from Amit, Urvi, and Shalini, and we've now got 3 more people who have joined the team.
What a
And that's
stupid. I like
Geeta
me.
Deshpande. Sanjay, you can clap for yourself too, Dr. Sanjay.
No, do it very good for me. I'm not doing it.
And Dr. Pratap Jechwani. So I'm really proud to say that we are now expanding team.
Sir, I'm going to trouble you more, sir.
And we look forward to have 3 more faces and new ideas coming on the social media team. But to wind up today's proceedings, I would like to thank all 3 of you. You all have done an excellent talk show, excellent discussion, Srinivas, very good moderation. You brought out the best in the faces and
I sent the question to Srinivas.
and I think we had so many aspects about diabetic foot, which must have been so helpful for all the listeners. I mean, all 3 of you are veterans, and all 3 of you have done justice to the topic. I really would like to thank all of you for sparing your time and giving it to us the last 1 hour. I think it's been extremely informative. We have our age-old custom of touching the feet, and we should never forget that touching the feet. It also holds true for our profession, because unless you touch the feet, you'll never be able to diagnose.
Absolutely.
So,
Absolutely.
we never should forget our traditions, because that's where something lies, and there's always a meaning to some custom. So thank you very much. With that, I would like to end the show today. We look forward to have you again on the show again and again. Thank you very much. Good night.
Thank you, sir. Thank
Stay
you.
tuned in
Dr. Das,
next
sir.
Thursday,
Sir,
7:30
was very
p.m.
nice.
again.
Thank you,
Thank
Sanjay.
you very
Thank
much.
you.
Thank you.
Thank you, Srinivas.
Namaste.
Thank you,
Thank you,
Sanjay.
sir. Kind of you, sir.
Thank
Always
you.
your blessings.
You can
and
stop the live.
guidance.
Thank you. Thank you very much. Thank you.